Welcome to the Psychiatry module of the Principles of Medical Science course. My name is Eric Messamore. I'm an Associate Professor of Psychiatry here at NeoMed. I am a psychiatrist, I'm also a pharmacologist, and I'm pleased to have recently become the Director of the Psychiatry curriculum for the Principles of Medical Science course. I am beyond delighted to introduce you to the field of psychiatry. This is a specialty that offers its students unparalleled opportunity to learn about humanity itself, while at the same time advancing human and medical knowledge. And when practiced well, psychiatry offers its practitioners daily opportunities to meaningfully impact the lives of some of the most vulnerable members of our society. So it's truly an amazing, intriguing, and rewarding medical specialty. However, I also feel that psychiatry is among the least well understood of medical specialties, and it's a sad fact that our patients and the illnesses that they suffer from remain amongst the most severely stigmatized conditions and people in our society. One reason why mental illness remains the subject of such stigma is because hardly anyone during the course of their education is given any comprehensible and useful framework for understanding about how the brain creates the thoughts and the moods which guide much of behavior. And this is very problematic because it's highly likely that an individual will experience at least some symptoms of mental illness during the course of a life, and being unable to understand why these things are happening to someone makes that person unnecessarily scared and fearful. And this lack of provision of a useful framework for thinking about such things is problematic on a second level, because as you'll see during this set of lectures, the mental illnesses are very common, and it is guaranteed that every member of society will encounter many individuals that are experiencing very severe forms of mental illness. And when confronted with people who have unusual or illness-affected patterns of thought, mood, or behavior, if we lack an understanding for how these things arise, we will default to positions of ignorance and fear and operate from positions of prejudice and stigma. So what I hope to accomplish in this short lecture will be to give you a basic framework for understanding what large portions of your brain are up to most of the time. In the process, I'm hoping that you will come to realize that considerable expanses of the brain real estate are neurologically silent. In other words, they can suffer damage to structure or abnormalities of function which are not reflected in physical signs, but instead are reflected in changes of mood, thought, and ultimately in behavior. And finally, during this lecture, I would like to provide you with a framework for understanding the nature of mood and how mood and thought interrelate and reinforce one another. Understanding these concepts, I believe, will help to facilitate an understanding of the nature of a lot of psychiatric disorders, and as I said, hopefully will begin to form the basis of a framework whereby the acquisition of psychiatric knowledge will become easier and more sensible. And it goes without saying, but I think I'll say it anyway, the brain is imponderably complicated. It weighs just 3 pounds, yet at less than 2% of the body weight consumes a whopping 20% of the energy burned in the course of a day in a human body. This is because it's composed of trillions of nerve cells, which are highly metabolically active and highly physiologically active. The business of the brain is to scoop up every bit of sensory information from the external world and from the internal world, and to process it at higher and higher levels to ultimately present us in our conscious minds with a representation of external and internal worlds with which we can navigate and survive in our world and in our relationships. And I mentioned in the previous slide that the job of the brain is to create a representation, and I want to emphasize the word representation, of internal and external sensory information to construct a coherent view in the conscious awareness about what's going on in these worlds. So I'm not at all embellishing or misrepresenting things when I say that all of our reality is a virtual reality. It exists as a series of electrical impulses and signals within a vast array of circuits, and the patterns of electrical activity within space and time in these elaborate circuits are ultimately what give rise to the memories and perceptions that we call conscious experience. So now I want to tell you a story. One evening in the emergency department, a wife and a daughter brought in the identified patient, a 70-year-old man, and they told us that all his life our patient had been extremely difficult and cantankerous, very difficult guy to get along with, and for the last 2 weeks he's just been calm. The family were worried because this represented a change in his behavior, and they wanted us to take a look at it. So we scratch our heads a bit and think about, how do you go about working up subacute onset of pleasant demeanor? The usual laboratory studies and physical examination and neurological examination were all entirely normal. So up to that point, we had no explanation. We did go on and got brain imaging and found a fairly significantly sized tumor in his right frontal lobe. And at that point, everything made sense. Frontal lobe controls, among other things, motivation and drive. So a tumor in that region of the brain could fully account for the behavioral changes that cause the family to bring their loved one in for evaluation. This particular real-life story from the ER illustrates an important neurological fact often overlooked, and that is that many areas of the brain are what are called silent, neurologically silent. And they're described as silent because damage to these areas of the brain, for example the frontal lobe, can quite often produce no discernible or detectable neurologic signs. They don't announce their presence, hence they're called silent. I'm not sure the right word to describe non-silent areas of the brain, so I'm just going to call them the noisy parts. And the noisy parts of the brain are brain regions that are directly connected to circuits that influence motor activity, or are directly connected to circuits that influence the perception of sensation. Damage to these areas will leave you with noticeable or detectable neurological deficits. And a really interesting observation is this. You'll see in the diagram I've colored the silent parts purple and the neurologically active or noisy parts are non-purple. And you'll see instantly that the amount of brain which is neurologically silent far exceeds the amount of brain which is neurologically talkative. On the basis of surface area alone, it's far more likely that a person is going to experience damage or dysfunction to a silent portion of their brain versus a talkative portion of their brain. Factor in the incredible complexity of the circuits and the extraordinarily high metabolic demand of the circuit components, and you have a recipe that practically assures the occurrence of dysfunctions that will primarily express themselves as disturbances of mood, thought, volition, or behavior. So I've just shown you how psychiatry is actually a form of neurology, except the object of our attention is the neurologically silent portions of the brain rather than the neurologically talkative ones that neurologists will be more focused on. So now I'd like to turn our attention to the topic of emotions. There are many possible explanations or theories around emotion, but the one that I think is more useful for physicians to understand in the context of a framework for thinking about psychiatry is that emotion is the word that we give to describe the feeling of physiology. Think about how a child acquires emotional language. The parent observes tension, constricted range of affect, possibly facial flushing, and all this in the context of a threatening situation. And the parent says to the child, "You look very anxious." The child then begins to associate that name, anxious, with how he or she feels internally, which is palpitations, tension, worries, and generally wired up. In other words, the child learns to associate the word anxiety with the physiological sensation of turning on the sympathetic nervous system. So in this very useful model, mood states are physiological states, plain and simple. Okay, great. So mood is physiology. Mood is the word to describe the feeling of a physiology. So what? So how does that help us understand thoughts and behaviors? Well, let me tell you a story. A woman in her 50s was admitted to the hospital in a state of bipolar mania. Her mood was off the charts good. She felt awesome. She felt like anything was possible. So much so that she began to get the idea that if she simply bought a lottery ticket, she was going to get $1 million. I'm going to elaborate on this point in a minute, but for now suffice it to say that her mood not only constrained her thoughts about what was possible, but in this case it actually enhanced her view of what was possible. So she felt like $1 million, and therefore, to her reasoning, it seemed probable that she could win the $1 million. So mood states, which are reflections of underlying physiology, have profound abilities to constrain or to influence or to dictate thought. So this is, I will explain in future slides to elaborate further this relationship between mood and thought. A simple way to think about this relationship is the feel makes it real, which is not quite true. The feel makes it feel real, but feeling real in many cases is a very short step to actually being perceived as real. And that's where a lot of difficulties in psychiatric syndromes arise. Specifically, the feeling can be so intense that the thoughts that go along with this feeling seem irresistible, seem impossible to negate, because to negate it doesn't feel right. So my patient with mania felt so incredibly good that it would be incomprehensible, almost incomprehensible, to reason her way out of it. In other words, she might be able on some level to entertain the possibility that she might not get the $1 million, but the underlying emotion of excitement and grandiosity and anticipation was so strong that that was only a sort of lip service nod to logic. Deep in her core, she knew that she was about to be a millionaire. Similarly, you'll find in your future career, if you encounter somebody with severe depression, the feeling of sadness and the feeling of being low goes along with the thoughts of, I am a desperate failure and nothing is going to work. Those thoughts are very consistent with the mood state. So you'll find that if you try to talk to that person and say, you're a good guy, I think you're likely to succeed, and point out things which may be very realistic, yet they don't feel consistent with the mood state, you'll find that not only does your patient not agree with you, but your patient may become a bit irritated with you because truly you're not listening to what he's saying. He is a desperate failure, and he has very great difficulty imagining himself in any other way because his mood is so strong that it's constraining those thoughts to only those which are consistent with the underlying mood. And the converse is also true. If you consistently get messages that you're a failure, you don't succeed, you don't meet the standards, and so forth, and if you begin to internalize these messages and repeat them to yourself, you'll find that those thoughts depress your mood. And as your mood gets depressed, as you actually change your physiology to be more in line with the depressed physiological / mood state, that mood will reinforce those thoughts, and then you'll set up a cycle whereby it's repeated and reinforced with each turn of the cycle. And so schematically it looks like this. Thoughts and moods set up reinforcing cycles. They reverberate with each other and amplify each other. Strongly negative moods can induce strongly negative thoughts, and strongly negative thoughts can induce strongly negative moods. And as emotions are aroused and thoughts are confirmed, emotions get more aroused and thoughts are reconfirmed. Not only are they reconfirmed, but they tend to be expanded. So you go from a bad thing might happen to a really bad thing might happen to the worst disaster ever is likely to happen. So this is a very vicious circle. The implications of this are straightforward. If thought and mood are related, we can help our patients to get better by affecting either one of those limbs. We can affect mood physiologically by using somatic treatments, treatments that affect body functioning, primarily the use of psychotropic medications. And I think it's important to say we call them psychotropic medications, but they affect less the psyche per se than they do the underlying substrates of the psyche, which is to say the physiological substrates of mood or perception and so forth. The other branch of the loop is the thought cycle. So we can intervene at the level of the physiology or the mood state, and we can also intervene at a higher or cognitive level by intervening at the thought cycle. We can help people to understand why it is that they may repeat certain mantra-like phrases to themselves that generate worsening of the moods. We can help them to reframe those things. We can help them to find new ways of looking at themselves, which are both more accurate and typically less distressing. So you can interrupt this mood thought cycle either on the mood side or on the thought side. To summarize, we've seen in this short lecture that psychiatry is the branch of medicine, more specifically the branch of neurology, which concerns itself with the symptoms that arise from neurologically silent regions of the nervous system. We've also seen that mood is the name we give to the feeling of physiology. It's not the only explanation of mood, but it's one that works very well for thinking about psychiatric care and psychiatric treatments. Mood and thought are very closely interrelated and mutually reinforcing, which can work to a person's betterment or to their detriment. But knowing of this interconnectedness, we now see why treatments that affect body physiology and ultimately affect things like mood and perception can be beneficial. And we should also be able to see at this point how looking at the level of thoughts can also help a person to affect beneficial change in their life. And since mood and thought feed off of each other, addressing both simultaneously offers the best chance for synergistic acceleration of recovery and longer duration of remission. I hope you found this introductory lecture useful and interesting. I would welcome your feedback. The next lecture in the series is going to be on the nature of psychiatric diagnosis. See you then.